Imagine trying to cure one of the most painful, invisible realities of aging using a centrifuge, your own blood, and, I mean, you might not believe this, the DNA of a male salmon trout.
Yeah, it really is a massive paradigm shift in how we view tissue aging.
It's wild. Today, we are bypassing traditional hormone pills and looking at the absolute frontier of regenerative intimate health. Welcome to our latest deep dive into the source material. We've laid out a very specific mission for you today, which is to decode the newest non-hormonal therapies for vulvovaginal atrophy, or VVA.
Right, and female sexual dysfunction, too. For a very long time, the medical community basically treated menopause and the tissue thinning that comes with it as just, well, an inevitable decline.
Just something to be managed.
Exactly. Typically strictly with hormone replacement therapy. But the cutting-edge science in these journals is taking a completely different route.
And just to give you an idea of the stack of sources we're pulling from today, we're looking at clinical case reports, real-world studies from journals like Clinical Case Reports International, and some highly specialized clinic protocols.
And we are seeing practitioners use elements like highly purified fish DNA to literally regenerate human tissue at a cellular level. It's fascinating.
So whether you are actively researching solutions for yourself or a partner, or you are just, fascinated by anti-aging and regenerative medicine, we're going to map out exactly how these cellular therapies work.
But before we get to the fish DNA, I think we have to understand the biological reality of VVA, or what the clinical literature now calls genitourinary syndrome of menopause.
Right, GSM. What is actually happening to the body here?
Well, to understand why these advanced solutions are even necessary, you really have to grasp the sheer scale of the problem. The sources point out that within just 4 to 5 years of menopause, over 50% of women experience severe VVA symptoms.
Over 50%, that's huge.
It's a widespread reality. And it's driven by a dramatic systemic drop in circulating estrogen and androgens.
I think people often hear, drop in estrogen and they immediately think of hot flashes or mood changes. But the sources go into intense detail about what that hormonal decline does to the tissue on a structural level.
Yeah, because estrogen isn't just a hormone. It acts like a signal telling the tissue to stay thick, moist, and elastic.
And when that signal disappears, the physical transformation is pretty drastic, right?
Extremely. The clinical texts describe a very predictable cascade of structural degradation. First, you see decreased elasticity. Then there is the flattening of vaginal rugae.
The rugae, those are the natural accordion-like folds in the tissue.
Exactly, the folds that allow for expansion and movement. When those flatten out, the tissue becomes rigid. But crucially, there is a massive loss of subepithelial collagen.
That's the connective tissue lying just beneath the surface.
Right, it's what provides thickness and resilience.
It sounds like the scaffolding of a building is slowly dissolving from the inside out. And from reading the traditional treatment protocols, it seems like the standard fix for decades has just been to paint over the cracks with over-the-counter moisturizers.
Yeah, or lubricants, which is just symptom management. When that biological scaffolding dissolves, the patient is left with severe dryness, vulvar itching, burning, and dyspareunia.
Which is the clinical term for painful intercourse.
Yes, and it isn't just discomfort. It severely impacts a woman's overall quality of life, her self-image, and her intimate relationships.
Now, I know estrogen therapies have been the gold standard here, effectively pouring concrete back into the foundation to stop the decay. But our sources spend a lot of time highlighting the limitations of hormone therapy. Why can't every woman just take estrogen and be done with it?
Well, accessibility is a major barrier. Systemic or even topical localized estrogen simply isn't an option for everyone.
Because of the cancer risk.
Primarily, yes. Many women, particularly those with a history of oncological disease like estrogen receptor-positive breast cancer, cannot use it. The fear is that introducing estrogen could potentially stimulate dormant cancer cells.
That makes sense.
Then you also have women with certain blood clotting disorders or other chronic conditions who aren't eligible. So this leaves a massive population basically suffering in silence.
Relying entirely on temporary relief because they've been told structural repair isn't safe for them.
Exactly.
Which brings us to the first major regenerative protocol found in our stack of research. It's a multi-layer approach using polynucleotides and hyaluronic acid.
Right. If we follow your scaffolding metaphor, this protocol is where we bring in the raw building materials and the master builders.
And this is where the science gets slightly wild. Because when we talk about polynucleotides, or PNHPT as they call them in the studies, the sources reveal something completely unexpected.
The salmon trout DNA.
Yes. These are highly purified DNA polymers extracted from male salmon trout gonads. Literally, fish DNA. When I read that, I had to stop and reread it. Why salmon trout?
The why is actually deeply rooted in evolutionary biology. It turns out that this specific DNA from the salmon trout is highly conserved, meaning its fundamental building blocks are remarkably compatible with human biology.
Oh, wow. So our bodies recognize it.
Precisely. Furthermore, it is extremely hydrophilic. It binds with water incredibly well. So when these highly purified polymers are injected into the vulvovaginal tissue, they don't just sit there. They undergo a process called enzymatic cleavage.
Okay, I saw enzymatic cleavage in the notes, and honestly, it sounds like a terrible sci-fi movie. What is actually happening in the tissue there?
Think of it like taking a massive, unusable log of wood and chopping it down into perfectly sized kindling.
Okay, I like that analogy.
Your body's natural enzymes encounter this long chain of fish DNA and slowly break it down, releasing nitrogen precursors, specifically nucleotides and nucleosides.
The raw building blocks of cellular life.
Yes. And these precursors directly feed the fibroblasts in your tissue.
And fibroblasts are the tiny collagen factories of the human body, right?
They are the specific cells responsible for synthesizing collagen and the extracellular matrix. So by constantly feeding these fibroblasts with the breakdown products of the polynucleotides, the treatment reduces local inflammation and forces the tissue to produce brand new collagen and elastin.
So you aren't just plumping the area, you are literally commanding the tissue to repair itself from the inside out.
Exactly.
I want to get into the specific clinical protocol outlined in the obstetrics and gynecology reports. The texts describe using a 30-gauge needle, which I know is incredibly fine, like what they use for facial aesthetics.
Barely thicker than a few strands of hair.
Right. And inserting it at a 30 to 45-degree angle using a linear retrograde technique. Now, if I'm listening to this, I'm thinking, 1, injecting anything into already painful atrophic tissue sounds agonizing.
That's a fair concern.
And 2, why does the specific angle even matter?
Well, to address the pain aspect first, practitioners utilize highly potent topical numbing creams beforehand. But the angle is critical. At 30 to 45 degrees, the clinician is intentionally targeting the subepithelial layer.
What happens if they miss that layer?
If you go too shallow, the product just sits in the dead outer layers of the skin. If you go too deep, you hit the muscle, which doesn't need this kind of structural rebuilding. You have to place the polynucleotides exactly where the fibroblasts live to get that regenerative effect.
Got it. And the linear retrograde technique caught my eye too. The clinician inserts the needle to its full length and slowly injects the gel as they pull the needle out.
Right, creating a smooth line of the product under the skin.
And for the more delicate areas like the labia minora and the clitoral area, they use tiny 0.1 milliliter microwheels, which are essentially just microscopic droplets placed precisely under the surface.
It requires an immense understanding of the local anatomy. The clinical literature details this as a 2-phase priming and consolidation methodology.
All right, so phase 1 is the primer. This involves 3 sessions of highly concentrated polynucleotides, specifically 40 milligrams in a 2 milliliter suspension, spaced 2 to 3 weeks apart. Why the gap between sessions?
The tissue needs time to work. You are providing the kindling, but the fibroblasts need a few weeks to actually manufacture the new collagen and elastin.
And then comes phase 2, the consolidator. After those first 3 priming sessions, the patient undergoes 2 sessions of hyaluronic acid, again at a concentration of 40 milligrams per 2 milliliters, spaced 15 days apart.
The hyaluronic acid acts as a moisture magnet. It deeply hydrates the area and essentially locks in the structural scaffolding gains that were just made by the polynucleotides.
Let's look at the actual results because the data from the real-world case series is staggering. Over 60% of women reported significant symptom relief within just 2 weeks of application.
2 weeks is incredibly fast for structural remodeling.
And the specific symptom reduction numbers are hard to ignore. Vaginal burning plummeted by 72.5%. Dryness decreased by 71.4%.
Those numbers represent a fundamental return of quality of life.
Yeah. And the sources reference a specific diagnostic tool called the FSFI-6, the Female Sexual Function Index. It's a questionnaire measuring desire, arousal, lubrication, orgasm, satisfaction, and pain.
Right.
In one case study of a 48-year-old woman, her score jumped from a severely impaired 6.0 all the way up to 24.0 after a 6-week follow-up.
For context, on that scale, a score of 19 or below indicates clinical female sexual dysfunction.
Oh, wow.
So this specific patient didn't just feel a little better. Her treatment clinically reversed her sexual dysfunction classification. She crossed back over the threshold into normal function.
But reading about that rapid decrease in tingling, soreness, and pain raises a question for me. Does this mean the fish DNA is actually healing the damaged nerve endings? Or is the hyaluronic acid just plumping the tissue around the nerves to act as a mechanical cushion?
Well, the literature suggests a combination of both mechanisms. The hyaluronic acid undeniably provides immediate plumping and massive hydration, which physically cushions the exposed nerves.
Right, providing immediate relief.
Yes. However, the sustained long-term relief from burning and pain strongly points to a neurotrophic effect from the polynucleotides themselves.
Neurotrophic meaning it's creating an environment that protects and repairs the nerves.
Exactly. In severely atrophic tissue, the nerve endings are essentially stripped of their protective environment. They become hypersensitive and misfire, causing that constant burning sensation.
That makes sense.
While the fibroblasts are building new collagen, the environment created by the breakdown of the PNs seems to support the health and regeneration of those localized nerve endings.
So fish DNA is great for bringing in external building blocks to rebuild the matrix from the outside. But what if the body has lost the robust blood supply needed to sustain that newly built tissue long term? How do we jumpstart the body's internal engine?
That requires a shift from external building blocks to autologous treatments. Autologous simply meaning the treatment is derived from the patient's own body.
And in this stack of research, that points directly to the O shot, which harnesses platelet-rich plasma, or PRP. I think a lot of people might have heard of PRP being used in sports medicine. You know, an athlete gets PRP injected into a blown-out knee to avoid surgery, or people use it for hair restoration. But the application in intimate health is a whole different ballgame.
The O-shot protocol is quite elegant because it uses the patient's own biological signaling system. It begins simply with a standard blood draw from the patient's arm, usually about 15 to 20 cc's of blood.
I was looking at the actual clinic protocols for the preparation, and it's incredibly specific. It says to take that blood, put it in a centrifuge with a special separator gel, and spin it at exactly 3,000 RPM for 10 minutes. Why so rigid? What happens if you spin it faster or slower?
That specificity is the difference between a successful regenerative treatment and a useless injection. The centrifuge uses centrifugal force to separate the blood components based on their density.
Okay.
If you spin it too fast, the extreme G-force will physically crush the platelets, destroying the very cells you're trying to harvest.
Well, yikes. And if you spin it too slow?
If you spin it too slow, the red and white blood cells don't fully separate from the plasma, so you end up injecting inflammatory red blood cells back into the tissue, which just causes swelling and pain.
So hitting that exact 3,000 RPM sweet spot leaves you with this golden plasma at the top of the tube that is highly concentrated with intact platelets.
Yes, and those platelets are the key.
The sources note that when this plasma is activated, it releases over 38 natural growth factors. What are growth factors doing on a microscopic level?
Growth factors are the body's natural signaling proteins. In a normal injury, like a deep cut, platelets arrive and release these factors to command the local dormant cells to wake up, start multiplying, and repair the damage.
So by concentrating them into PRP, we are artificially flooding the atrophic tissue with these emergency repair signals.
Precisely. After a strong local numbing cream is applied, the clinician uses a very fine needle like a 31 gauge to inject this concentrated healing serum directly back into the patient.
And the targets are very specific, usually 1 cc into the clitoris and 2 to 4 cc into the anterior vaginal wall right near the G-spot.
Right. And the biological mechanisms that follow this injection are where the real magic happens. The texts talk extensively about angiogenesis and neurogenesis.
Let's break those down.
Angiogenesis is the creation of brand new blood vessels from pre-existing ones. Severe atrophy is characterized by a lack of blood flow. The PRP signals the tissue to build new microscopic capillaries, drastically improving circulation to the area.
And neurogenesis, similarly, is the stimulation and growth of new nerve tissue.
Exactly.
So for the listener trying to understand the tangible impact of this, the dual benefits are profound. On one hand, you have the sexual function benefits. Because of the new nerves and increased blood flow, there is a dramatic increase in sexual sensitivity, natural lubrication, and arousal.
Some of the sources cite over 90% of women reporting improved pleasure.
That's incredible. But on the other hand, there is a purely functional anatomical benefit regarding the bladder.
Yes. The injection into the anterior vaginal wall fundamentally thickens and strengthens the tissue there. That specific wall sits directly underneath the urethra.
Okay, I'm visualizing this.
When that tissue is plump and strong, it provides a solid backboard for the urethra to compress against when there is sudden abdominal pressure.
Meaning it effectively addresses mild stress urinary incontinence.
Yes. It treats a mechanical issue bladder leakage during a sneeze, a laugh, or a heavy workout by structurally rejuvenating the supportive tissue, rather than telling a woman to just do 1,000 Kegels a day or resorting to invasive sling surgery.
This raises an interesting point about how these therapies are actually deployed in the real world. Treating severely atrophic damaged tissue isn't always a one-and-done miracle shot.
No, rarely.
The clinical protocols show that modern doctors aren't just picking one of these therapies, they're combining them. They are stacking these treatments for compounding benefits.
We are definitely seeing the frontier of customized regenerative medicine in these protocols. The practitioner assesses the specific deficits of the tissue and builds a custom repair plan.
For example, the sources detail a stacked protocol called the vampire wing lift. This combines the autologous PRP we just discussed with hyaluronic acid dermal fillers.
Right, similar to Juvederm.
That makes total sense.
Yeah.
You get the instant gratification of volume restoration in the outer labia from the thick dermal filler, which provides immediate physical cushioning, while the liquid PRP injected alongside it works quietly in the background over several months.
Exactly, regenerating the actual blood supply and nerves. There are also highly aggressive protocols combining PRP with thermal energy devices.
Oh, right, the lasers.
Yes. One of the clinical studies highlighted a protocol using a hybrid CO2 10,600 nanometer and 1,500 nanometer laser applied internally to the vaginal area, followed immediately by PRP injections.
I love the analogy one of our researchers used for this. The laser creates thousands of microscopic controlled injuries in the tissue. Then you flood that freshly damaged tissue with the potent growth factors from the PRP.
It's exactly like aerating a lawn by poking holes in the dirt and then immediately putting down liquid fertilizer.
The fertilizer seeps deep into the roots instead of just sitting on top of the dry grass.
That synergy radically enhances the tissue remodeling process. The controlled damage from the laser forces the body's immune system to pay attention to an area it had largely abandoned.
And the PRP provides the raw, concentrated materials needed to build it back stronger and thicker than before. Now, I want to pivot to a specific clinical protocol I noticed for combining autologous PRP with the intimate polynucleotides, the fish DNA, in severely thin atrophic tissue.
Okay, yes.
In our stack of sources, they detail the PRP protocol and the polynucleotide protocol as distinct, separate pathways for the intimate area. But there was this passing note about hair restoration, where practitioners are already combining PRP and polynucleotides in other medical fields to maximize cellular repair.
It is a highly observant connection to make. The sources confirm that a standardized, universally published protocol combining both simultaneously specifically for VVA isn't explicitly detailed in these gynecological texts quite yet.
Right.
However, the theoretical application is clear to anyone looking at the distinct mechanisms. If a clinician were to stack them based on how they work in hair restoration, they would likely use the polynucleotides first to prime the tissue.
To feed the fibroblasts and reduce the baseline inflammation.
Exactly. And then, once that matrix is stabilized, they'd introduce the PRP to trigger robust angiogenesis and neurogenesis in that newly optimized environment.
Okay, but I have to push back a little here on behalf of the patient. With all these lasers and centrifuges spinning blood and highly purified fish DNA injections, aren't we risking just completely overwhelming the patient?
It's a completely valid concern.
I mean, a woman comes in suffering from severe dryness and painful intercourse. How does a doctor even decide where to start without making her feel like a science experiment?
It highlights exactly why this field requires specialized training. We are moving away from the era of the one-size-fits-all daily pill, where every patient gets the exact same prescription regardless of their unique anatomy.
Right.
A skilled regenerative practitioner doesn't just throw every laser and needle at the patient at once. They assess the exact anatomical and functional state of the tissue.
So they're looking at whether the primary issue is structural or vascular.
Precisely. If the primary issue is a complete lack of structural scaffolding and severe thinning, they might start with polynucleotides to rebuild the foundation.
And if the structure is okay,
if the tissue structure is decent, but the issue is a profound lack of sensitivity, blood flow, and mild incontinence, the O-shot might be the first line of defense.
it's a highly customized, targeted repair job. It's respecting the complexity of the human body rather than just trying to temporarily numb a symptom with a topical cream.
The overarching goal is not just symptom management. It is about restoring the tissue's function and cellular age to its premenopausal state as closely as biologically possible.
To sum up what we've discovered in the sources today, severely thin atrophic tissue, that dissolving scaffolding we talked about at the beginning, is no longer a permanent sentence.
Definitely not.
It is not just an inevitable reality of aging that you have to silently endure. Through the incredibly precise application of polynucleotides to rebuild the collagen matrix from the outside and autologous platelet-rich plasma to generate new blood vessels and nerves from the inside, medical science is finding real, tangible ways to reverse the clock on intimate health.
And, the data in these clinical reports raises a philosophical question about medicine. It's something to ponder long after we finish today.
What's that?
We have spent decades and billions of dollars looking for synthetic chemical cures to the aging process. But if a centrifuge spinning your own blood at 3,000 RPM and the purified DNA of a salmon trout can effectively teach one of the human body's most complex, sensitive tissues how to completely regenerate itself, what other irreversible signs of aging are simply waiting for us to discover the right cellular instructions?
A completely wild thought to end on. From a broken scaffolding to a fully regenerated foundation. Thanks for exploring the science with us today.